In this video, we'll be discussing infectious disease epidemiology, and our learning objectives are to describe the epidemiologic transition, discuss the relationship between agent, host, and environment characteristics in infectious disease, define herd immunity, identify which disease has been eradicated, and distinguish between various epidemic curves, those associated with propagated and point source outbreaks. So in 1900, the leading causes of death were a mixture of infectious and non-infectious diseases. You see the two leading ones, or the three leading ones, were all infectious: pneumonia or influenza, tuberculosis, GI infections. But by 2010, we largely have shifted to more chronic diseases as leading causes of death. And this is what we call the epidemiologic transition, that shift from primarily infectious diseases causing morbidity and mortality to chronic diseases being the leading causes of morbidity and mortality. Nonetheless, infectious diseases are still an important issue in public health. And here we see the epidemiologic triangle that we often discuss when talking about infectious diseases. And this triangle is designed to represent the fact that disease is a result not just of a single factor, not just of an infectious agent, for example, but it has to do with the interaction between the host, that agent, and the environment. So host characteristics are personal traits of people or populations. This could relate to age, nutritional status, susceptibility. Environmental characteristics are things like climate, population density, and then agent or pathogen factors are those things like how easy it is for it to spread, how likely it is to make people sick, and whether it's susceptible to treatments like antibiotics. So we could intervene on any one of these three factors to try to prevent disease. So at the host level, that might be treating people or isolating people who are sick, providing immunizations, or trying to boost that nutritional status. In the environment arena, we could try to improve housing, make safer water, and provide preventive services. And then for agents, we could try to eradicate them, eliminate them from the environment, or genetically modify them in some way that makes them less likely to cause disease. So in addition to being able to intervene at those 3 points, we could also try to break the links between any two of them. So you can see suggested interventions at the arrows in between each one. So in order to prevent disease by interrupting the host and agent interaction, we could protect people. So, provide bed nets, those types of things, so they don't come into contact with the pathogen, educate people about how to protect themselves or otherwise alter their exposures. When thinking about the agent and environment interaction, we could try to remove breeding grounds for the agents responsible for transmitting disease, improve sanitation. And then between host and environment, again, we can try to educate people about risks and protective factors, change people's activity patterns, or try to implement quarantine. So we've talked before about these definitions, but just as a reminder, endemic refers to an expected number of cases happening in a population. Epidemic is a time period when we go beyond those endemic levels. And then a pandemic is when we have a worldwide epidemic occurring. Also, there are two broad classes of transmission that we think about with infectious diseases: direct, which would include physical contact, and indirect, which includes something like a vector or a vehicle that spreads the disease to people. So although we now accept the germ theory of disease and recognize that various agents are capable of causing disease in people, this has not always been true. So just a few quick examples. We talked before about John Snow mapping the cholera outbreak in London and demonstrating that this particular water pump was likely the cause of at least part of the outbreak. And that case really reflects the idea that we don't always need to know exactly what the causative agent is in order to stop an outbreak. So he was able to break the host environment interaction by removing this pump handle, so by changing people's access to potentially contaminated water. Ignaz Semmelweis was working around the same time as John Snow in the kind of early mid-19th century, and he demonstrated nicely that hand washing could actually prevent the spread of disease, even though it wasn't exactly clear what the disease was. He was working in a hospital and noticed that the labor and delivery floor that was attended by medical students had higher rates of what was called childbed fever, which was probably just a staph infection, but that this medical student ward had higher rates of infection and death among women post-delivery than the floor where it was mostly women coming off the street who were attended by midwives. And so he, through a series of events, including a friend of his who worked in the morgue and started exhibiting symptoms of childbed fever before he died, Semmelweis hypothesized that there was some agent that was being transmitted that was causing this infection and death, and so had the medical students start washing their hands and observed that their infection and mortality rate did indeed drop below that of the midwife unit. Nonetheless, he was kind of shunned by medical societies, and it was many more decades before hand washing became common practice. And even more recently, even in the 80s, although we recognized infectious agents and understood how diseases spread, when HIV first emerged, it was called gay-related immune disorder, which kind of attached a stigma to it and made lots of people feel like they weren't at risk. And so I think it's worth noting that even when we have knowledge about infectious diseases and agents, the way we talk about them can influence people's behavior and their perception of risk. And so I think choosing that poor name for the disease initially prevented some people from taking protective measures. If you're interested in learning more, Radiolab did a really nice piece on AIDS, and the link is there. So this is just a reminder about John Snow's map. Again, he used descriptive epidemiology to identify this particular pump in the middle of the city as the potential source of this cholera outbreak. When we talk about infectious diseases and public health, it's always important to remember that we have this balance that we need to be aware of between individual liberty and the public good. So we do have very broad public health authority in the US. Some of our earliest laws actually are related to the control of infectious diseases. Because this is something that affects many people and can be transmitted from one person to another, it's important to have kind of a broader perspective. So this is really a lot of the reason that we have compulsory vaccination or vaccination laws. We'll talk more about herd immunity later in this session, but recognizing that, and there are cases in which we need to put our individual liberty subservient to the public good. Vaccines are one example of that. Another issue we often face in public health is considering isolation and quarantine. So isolation is when we ask people who are not healthy, who have become sick already, to separate themselves from the public to prevent transmission. And most people are relatively fine with that approach. But quarantine can become a little bit more problematic. That's when someone who's not symptomatic is asked to separate themselves because there's a risk that they might become ill. And so that's the source of lots of movies and concern about the quarantine aspect of that. One example of isolation was of Typhoid Mary Mellon, who worked as a cook in homes and transmitted the disease to several people, and some of whom died. But she never had any symptoms, and so it was hard for her to believe that she was the cause of the disease. We, of course, now know that it's possible to be a healthy carrier of typhoid, but this resulted in her needing to be separated since she continued to work in different homes. So 2 more links to Radiolab stories about her if you're interested in that. So how do we identify epidemics? Well, largely we use surveillance. We talked about this in the last module. It's a systematic data collection system. And we have the reportable disease list, which covers many of the infectious agents that we encounter. And influenza often has its own sort of system carried out by county health departments to identify early cases and see what strains are circulating in a given year. We can also establish an epidemic threshold using historic data so we have a sense of when we are experiencing outbreak of disease. So we've seen this slide before, and this is showing the pneumonia and influenza deaths. And this is just an example of what an epidemic threshold curve could look like. And again, when we see these peaks that indicate an outbreak, it's a kind of red flag that something might be going on, and it would be worth investigating to intervene to bring those rates back down below the epidemic levels. So how do we measure epidemics? One useful calculation that we use is the attack rate. And this is just the total number of new cases of a disease that occurred during the epidemic period divided by the total number of people in that population who are at risk during the epidemic. So this is just an incidence rate. And this can help us identify the causes of outbreaks in some cases, especially when we have a foodborne illness outbreak. We can also use information about when people first became sick to plot epidemic curves. So point source exposure is caused by a single exposure at some point in time, and this typically results in a steep peak curve, while a propagated epidemic could be caused by multiple different exposures over a long period and therefore has a less steep curve. So here's an example of a point source outbreak. So we have an index case, one person who became sick, and then we see this very steep curve that then dies down. And typically, as you'll see here, the first case, the beginning of that curve, would be expected to start around the minimum incubation period time. The peak should be somewhere around the average incubation period time, and then it would start to decrease after the maximum incubation period. And this slide shows a propagated epidemic where we have that index case, but instead of just one single peak on our curve, we see multiple peaks, and often they grow, as is shown here. So each person in that earlier peak may have kind of started their own little epidemic curve, which means that more and more people are becoming sick. So returning to that attack rate idea, we said this is just an incidence rate of disease among the exposed. And case study 2.1 in the textbook has an example of this. So there's an outbreak of a foodborne illness at Bluegrass Hospital. And this table shows how you would set up an investigation that utilizes an attack rate. So you would want to collect information from people who are both sick and not sick. In this case, it's just a single hospital cafeteria. So if you could contact everyone who had eaten there that day, that would be the ideal situation. And then ask them if they had eaten or not eaten all of the food items that were available that could potentially have been the cause of the illness. So once you tally all those up, you would calculate an attack rate. So for apple juice, we see that there were 50 people who drank apple juice and 10 of them became sick. So our attack rate is just 10 out of that 50, or 20%. And then we repeat the same calculation among the people who did not drink apple juice. So 250 people did not drink apple juice and 40 of them became ill. So the attack rate in the unexposed group is 16%. And then we just calculate a relative risk. And so that's just the attack rate in the exposed group divided by the attack rate in the unexposed group. And so here that's 20% over 16%, and we get a relative risk of 1.25. So that means that people who drank apple juice are 1.25 times more likely, or 25% more likely, to have become sick compared to people who didn't drink apple juice. So we can go down the rows here and look at our relative risks. And basically what we're looking for is a large number. So if there's a high relative risk, it means that that food item is likely to have caused the disease. So in this case, we see that taco salad is pretty big. People who ate taco salad were 3 times as likely to become sick as people who didn't. But the really big one that stands out in this is the chipped beef with sauce with a relative risk of 28. So people who ate the chipped beef with sauce were 28 times as likely to become sick. So that would be our primary concern, our leading potential cause of the outbreak here with taco salad as a potential backup. And maybe it's the beef, maybe there was beef in that taco salad that was contaminated. Maybe some people who had taco salad ate the sauce, or maybe people just tended to eat both together. So the steps in investigating an outbreak are to start by confirming it. So we want to make sure that we are indeed seeing more cases than we would expect at an endemic level. And then closely related to step one is to verify the diagnosis. So make sure we actually know what disease or illness that we're working with, and that it's not multiple conditions that are presenting in a similar way. So once we know we have an outbreak and we know what the outbreak is being caused by, we would want to come up with a case definition. So that would include features like the timing of when someone became sick, what their symptoms are, and whether or not there's a test for it if they need to test positive. Then we try to find cases and record information about their experiences. We'd also want to contact anybody who is potentially exposed so we could compare those cases to people who didn't become sick, as we saw in those attack rate tables. Then we'd want to collect person, place, and time information to construct some descriptive epidemiology around the outbreak. From that, we developed hypotheses, as we did here. Our hypothesis would be that this chip beef with sauce is the cause. And then we'd want to test that hypothesis. So maybe there are still some samples of the food, or we could evaluate the food preparation methods to see if it's clear whether something went awry. And if our first hypothesis doesn't pan out, we need to reevaluate, come up with new hypotheses, and test them as necessary. And once we have settled on a cause, we'd want to implement control strategies and also prevention strategies to be sure that it didn't happen again, and then communicate findings. So in this case, both to the hospital and probably to the public, we want to let people know what the cause was, what the resolution was. So only one disease has successfully been eradicated, one infectious disease, and that's smallpox. Two others are close, polio and dronchioliasis, or guinea worm. And there are links there. I won't spend time on them, but I encourage you to visit the sites to learn more about those efforts. Then there are a lot of infectious diseases that it's unlikely we'll ever be able to eradicate. Influenza is probably at the top of that list. And the things that make them challenging to eradicate are the presence of reservoirs outside of humans, rapid mutations, so that's the issue with influenza. There are two different proteins that are kind of the hallmark or signatures of the disease, and they very rapidly mutate, and they also cross species. So that makes it unlikely that we would be able to eradicate them. Regardless, for both classes of diseases, those that can and cannot be eradicated, vaccines are an important prevention effort in public health against infectious diseases. So we mentioned herd immunity earlier, and this slide shows you visually what this concept is. So in all three of these blocks, we have two people who are sick with the disease, and then we have different levels of immunization within the population. So at the top, the blue people represent unimmunized people who are still healthy. So in a population of completely naive people, if someone becomes sick, it's likely that the majority of that population will become ill with the infectious agent. If a handful of people in that population are immunized, it's still likely that that disease will spread, maybe somewhat less rapidly, but there's still enough contact between unimmunized people that virtually everyone in the population will become sick. But on the bottom, we see the situation in which the majority of people in the population are actually immunized against the disease. And so we see a substantially reduced spread of illness from those two cases. Only one additional person becomes sick because of their proximity to someone who is ill. So herd immunity is the concept that if most of the population is protected against a disease, even if a small number of people within that population become sick, it's unlikely that they would interact with another unimmunized or naive person within the population. And so outbreaks will not happen as frequently. So when we think about this from a public health perspective, we often try to, we set thresholds for what percentage of the population needs to be immunized in order to prevent outbreaks. So for most infectious diseases, it's around 80%. You can see on this table here, the threshold percentage is that threshold for herd immunity on the right. And another factor in thinking about the spread of disease is this reproduction number, R0 in this table. So that's the number of people that one infected person could pass the disease on to in an unprotected population. So if someone had mumps, it's not as likely that it will spread. So only 4 to 7 people will probably become sick from any one person with mumps in an unimmunized population. And that results in our herd immunity threshold level being somewhere between 75 and 85%. And you can see here that in general, as the R0 increases, or as that reproduction number increases, so does the percentage of the population that we need to immunize in order to reach herd immunity. So once we get up to pertussis and measles, which are pretty easily transmissible, we need closer to 90% coverage to achieve herd immunity in a population. So these next few slides just show the success that we've had with vaccination in the US. So here is the number of cases in thousands of measles by year. This only goes from 1950 to 1977, but you see this dramatic decline in the mid-late 60s after the vaccine for measles has been licensed. And it continues through the 80s, and then starting in the 90s, we start to see this increase. And so this is the success of vaccines has also contributed somewhat to people's perception that the risk of vaccination outweighs the benefits. If there's very low rates of disease in the population, we reach a point where most people haven't experienced disease or don't know anyone who's experienced disease. So it seems like it's unnecessary to vaccinate. But as we've seen in recent years, when those percentage vaccination coverages start dropping, we start to lose some of that herd immunity protection. So this slide here showing pertussis cases from 1922 to 2015 illustrates that somewhat. We see this, again, dramatic drop after the licensing of the vaccine. But starting in the mid-2000s, we start to see this increase as vaccination coverages have declined. We've had more outbreaks of pertussis. So still nowhere close to where we were pre-vaccination levels, but certainly more than the trough that we experienced in the 80s and 90s. And this graph shows pertussis again, but by age group. And so we can see that the incidence is highest among infants under 1 year of age. And that's a very high risk group. Pertussis can be deadly for young infants in particular. But it shows that it actually increases for all age groups. And so there's now a recommendation that people get a booster shot, especially if they're going to be interacting with infants or young children, to try to prevent the spread of disease, since it seems like immunity does wane over the lifetime. And returning to the influenza example, I just wanted to mention the 1918 H1N1 influenza pandemic, which was estimated to kill 50 million people worldwide. And it was going on around the same time as World War I, and killed more than twice as many people as died in the war. So this was a very high mortality rate infection, especially among younger adults, which is unusual for influenza. And as a result, the US life expectancy actually dropped by 12 years after the 1918 flu outbreak. So just a reminder that it is still a serious threat. And in recent years, we of course have seen the swine flu and bird flu and some concern around those. And it really is just because it's difficult to predict what strains will be out there and when a new strain might emerge. Oops.